So good morning all. So we are going to start a new session is hot topics in glaucoma, Grand Glaucoma Debate. I think it will be the very interesting session. So I will request Dr. Benjamin, please come on stage. Dr. Benjamin is here. Dr. Joseph. कौन है? कोई नहीं है। और कौन है? ये May I request Dr. Wu to come on the desk.
Anybody here?
So our first debate is going to be what is next if trabeculectomy fails, tube revision, and what next if trabeculectomy fails tube. So our first speaker will be Sonika Porwal. I request Dr. Sonika to come on the desk.
What next if trabeculectomy fails? Good morning, one and all present here. I'm Dr. Sonika Porwal. And by the end of my talk, I'll make sure that everyone gets convinced that trab revision is the best method. Multiple factors contribute to the failure of filtering surgery. Most common one is subconjunctival fibrosis. And with a previously failed trabeculectomy, this risk is even higher. Rate of failure has been reported to be as high as 23 to 51% at 5 years and 52 to 59% at around 15 years, even with anti-scarring chemotherapy. So what's next? Do we repeat a trabeculectomy? There are various studies done. Long-term outcomes of repeat trabeculectomy have been shown that the failure rates of retrabs are from 59.7% to 68%, which are too high. A study conducted by my dear opponent, Dr. Sujini Shroff, she stated that failure rates are around 40 to 70% for retrabs, and also said that in countries where patients may not be economically sound and only a few surgeons may be trained in drainage implants, even glaucoma drainage devices may not be a good option. So do we put glaucoma drainage devices? Treatment outcomes in primary tube versus trab study, after 5 years of follow-up, have shown the failure rates to be around 33 to 42% in tubes and 28 to 35% in trabeculectomy, with a complication rate of around 50 to 58%. So can we not rescue a failed bleb? Who is our superhero? Yes, it's a small needle. It is needling. Needling is like a CPR. It's like a CPR of the bleb. Why not try it? There is no harm. A systemic review and meta-analysis done to study the safety and efficacy of bleb needling with antimetabolite after trabeculectomy failure was done, and it showed that the reduction in IOP of around 9.74 millimeters of mercury, with a complete success rate being 45.9% and a qualified success rate was 70.4%, which is very good. The anti-glaucoma medications, around 20 studies had a record of reduction of anti-glaucoma medication usage before and after bleb needling. Needling will also alter the morphology of failed bleb. Flat blebs and scarred blebs will look like a diffuse filtering blebs. I don't say that there are no complications. Conjunctival hemorrhage, hyphema, bleb leakage are the most common complications which can be handled by observation and by conservative methods. So why bleb needling? It is cost effective. This surgery is minimally invasive. I would call it a procedure. And it is repeatable. Compared to retrabeculectomies and tubes, no new conjunctiva is involved. It is less invasive. Cost can range to 0 to 10,000 depending on where do you do the needling. It is repeatable, and post-op care is also less when compared to a retrab or a tube. So I conclude the procedure does not sacrifice a new region of fresh conjunctiva. It can be repeated. The revision may be performed at the slit lamp in a minor procedure room or in a main OR. In younger patients, performing needling first may buy you 2 to 3 years and keep more options available for future. Exhausting salvage measures before resorting to resurgery is the art of preserving what remains while striving for what is possible. Thank you.
Thank you, Sonika. So our next speaker will be the Sujini Swarop. She is speaking on what is next if trabeculotomy fails tube. Over to you, Sujini.
Good morning, everyone. Thank you for this opportunity.
She's not able to see the slides here.
So, in the words of Albert Einstein, if you do the same thing over and over again, you cannot ever expect a different outcome. Similarly, with a trabeculectomy, if you do the same procedure, it would be unwise to expect a different outcome. So what are the challenges of trabeculectomy revision? The first is unpredictable success. Even with needling, with MMC, fibrosis can still occur. We have seen that with any incisional surgery, fibroblasts can migrate, and scar tissue is the main barrier for success. Whenever we see such blebs, we have sleepless nights. These thin, avascular, cystic wall blebs, which have high risk of hypotony, leaks, overfiltration, and infections. And we know that there are poor outcomes in high-risk eyes like uveitic, neovascular, and post-vitrectomized eye. So why is tube surgery the better option? The first main point is it bypasses the conjunctival fibrosis. We know that a trabeculectomy needs good conjunctiva to form a good filtering bleb. But in case of a tube, you can do it in not so pristine conjunctivas too. And also, you can be flexible in location. We don't have to concentrate just on the superior quadrant. We can even do an inferior tube. So it makes it extremely adaptable to a wide range of glaucomas, including primary and secondary glaucomas. So in this video, it shows in a belt buckle. Post removing the belt, we can still do a tube. So like my dear friend Dr. Sonika said, cost. There is definitely a cheaper variant of the tubes, which is the Orolab aqueous drainage implants, which can be done for not affordable patients. And we have seen consistent long-term IOP control with fewer post-operative interventions, like no needling, lesser injections, and less frequent post-op follow-ups. So the debate of trab revision, repeat, and tube is going on for many years. So evidence has shown that in bleb needling, the success rate can be between 50 to 80%, and we've seen the blebs with late bleb needling, small centralized blebs, and high pre-needling blebs to do more poorly. When it comes to the success of retrabeculectomy, it ranges between 30 to 80%. Dr. Sonika has quoted our study, but actually that study was a very short follow-up of only 6 months, a retrospective study. But we have seen that a history of prior filtering surgery does not affect the outcome of glaucoma drainage device. So even after a decade, the trab versus tube, the TVT study is still relevant in practice. So though there's a sustained IOP reduction in both trab and tube and similar number of medications, we have seen that the number of the trabeculectomy with MMC had a higher failure rate, almost 47%, and the most common reason was inadequate control of IOP. Also, trabeculectomy with MMC had a higher rate of reoperations and more early postoperative complications. A more recent study, a more recent meta-analysis of 49 studies with 16 high-quality RCTs, which compared the implants with trabeculectomy, showed that the Ahmed glaucoma valve had comparable IOP reduction, but it had very few complications like these hypotony and bleb leaks. when we look at Bowelt with trabeculectomy, though TRABs achieved slightly better IOP reduction, the qualified success was much higher in Bowelt, and the safety profile was also favorable. So in conclusion, my good friend Sonika actually missed the target a couple of times. The first being TRAB revision is less invasive. That's a false sense of security. Any procedure, even as simple as a bleb needling, can still have its complications. Tubes are reserved for secondary glaucomas. That could be outdated thinking because it's definitely essential in secondary glaucomas, but they have shown that primary glaucomas also do well when a TRAB fails. Tubes are expensive, misleading argument, there's an ADI, and tube should be the last resort, but why delay the inevitable? Why waste time on a strategy that has already proven unreliable? So in summary, the secret of change is to focus all your energy not on fighting the old, but on building the new. Thank you.
Thank you, Dr. Sujani. So to summarize the debate from Indian perspective, we have Dr. Shikha Gupta from AIOS. So Shikha, 2 minutes to you.
So I think Sujani and Sonika have really made my job difficult, and now the ball is in my court. So, so let's see. So any decision that a glaucoma surgeon takes depends on many factors. So it's a case-to-case basis. We can't have a blanket rule that retrab is better or a tube is better for a resurgery. So it depends on pattern of failure, patient characteristics, and the target IOP goals. So we can categorize actually TRAB failures into 2 categories. First is the early aggressive subconjunctival scarring. So if a patient comes immediately after surgery with a failed bleb with a kind of Tenon's response and very high IOP, retrab or needling is not a very good option in these cases. And however, if the TRAB has been doing well for a few years and later on it comes out with focal scarring and failure, in that case with a ring of steel appearance around the scleral flap, needling, same site revision or retrab is a better option in these cases because we know that the conjunctiva has been filtering in these eyes. Other than the conjunctival status, it also depends on IOP reduction goals. If the patient is young and we need to give him more life years of functioning surgery, then with the TRAB or a needling, we can give him few years of, before doing a more aggressive surgery like a GDD. And same site bleb revision with antimetabolites are better. So when we come to the glaucoma drainage devices, so early TRAB failures, better to go for glaucoma drainage devices. TVT also shows that the results were almost equivalent for both complications and the IOP control rate. Inflammatory glaucomas, again, there is a better probability with GDDs to do better. And they, of course, give us a better long-term IOP control compared to trabeculectomy. So we have to weigh in what is best for that patient. So in summary, because Dr. Amit wants to be really tight with the time schedule, it's a tightrope, it's not a cakewalk, and we as glaucoma surgeons, we should do whatever our skill set allows us, whatever the patient demands allow us, and whatever is best in our knowledge. So as Krishna says in Gita, that we should do our duty with full knowledge and without attachment to the results. But as every fire is covered by smoke, similarly, every work that we do may have some outcomes which may be undesirable, but then that may be patient's destiny. So do your best, and then what can be done if it doesn't go the way we desire. Thank you very much.
Thank you, Dr. Shikha. And I would request Dr. Benjamin Zhu, international stalwart of glaucoma from USA, to give his perspective regarding this debate. I mean, the audience should get a take-home message with this 2 debate.
Hello? Oh, wonderful. So thank you to the speakers for all your excellent talks and sharing your perspectives. I would like to propose a different alternative here, which is that why not do both? So I think the argument about the TRAB revision is that if it doesn't work, then you've lost time in bringing the pressure down for your patients. And for the tube approach, well, you have a potentially salvageable trabeculectomy. So typically what I'd like to do is a Barvelt, either 250 or 350. And so when we tie off the Barvelt, it can take a period of time for it to start working fully. And so at the same time, I think it's worthwhile to perform a TRAB revision, needling in the operating room, where it is much more comfortable for the patient and more comfortable for the surgeon as well, in order for you to have the highest chance of success. So typically you'll put down the plate, seal up the conjunctiva, and then perform the bleb needling. So I think here the most important thing is that you're probably taking the patient to the operating room to control the IOP. This will hopefully provide you with at least short-term IOP. Yes, the trabeculectomy site may scar down again, but then by that point, hopefully the tube shunt will be working. And we know that the tube shunt, the flow of the aqueous is more posterior to healthier conjunctiva compared to the conjunctiva closer to the limbus, which was exposed to mitomycin. So I think both are excellent approaches, but you may also want to consider combining both together.
Thank you, Dr. Benjamin, for summarizing very nicely. So our next speaker will be Dr. Somendranath and Dr. Prasanna. I would request both of them to take one podium on each side. Dr. Prasanna. Huh? So we'll start with Dr. Somendra Ghosh, and the rebuttal will be given by Dr. Alukesh for this particular debate. And then we'll have Dr. Keith summarizing the debate.
Somendra, yes. Above one. The first one, four, first one.
That's what we wanted actually. So can we have the slides of Dr. Somendra?
Not video, not video. PowerPoint presentation, yes. Yes, good morning everyone. Thank you for the opportunity. Today I'll be talking on failed GDD, and my bet is on excisional bleb repair or EBR. So what is a failed GDD? Is uncontrolled IOP following a GDD implantation despite maximal medical therapy is known as failed GDD, and it has been found in one study the median age of failed GDD usually 3 years after the implantation and ranges from 1 year to 5 years. Now, what are the causes of a failed GDD? It may be tube related, in which the tube is closed by iris or vitreous, and it can be easily identified in slit lamp. On the other hand, it may be plate related, in which the encapsulation happened. Encapsulation means fibrosis around the episcleral plate, and encapsulation is found to be the leading cause of long-term failure in GDD. Now, what are the options we have if the encapsulation happen? Then we can go for a sequential GDD or put a second GDD, or we can go for cyclophotoablations, we can go for needling of the bleb, or we can go for excisional bleb revision. Now, how do we do the excisional bleb revision? I will give you a short video over there. So it's a case of AGV. You can see the tube is here, and this part is the encapsulated part, or a kind of tenon cyst, you can say. So I will start with the dissection of the conjunctiva and tenons, so to separate the cystic structure from the conjunctiva and the tenons. So I have to separate it from the tenons. And after that, I have to incise the cystic structure, and I have to be very gentle to not to damage the plate structures of the AGV. So as it is a cystic structure, when I enter into the bleb, you will see the gush of fluid will coming out from that area. Just see, the gush of fluid is coming out. That means I have entered the full thickness. After that, I have to dissect a 3x3 or 4x3 rectangular flap area from the above the GDD and remove it. So this is a rectangular part of the fibrotic tissue, and it was removed. And after that, it's very easy. You have to suture it, cover the conjunctiva tenons over it. So what is the result of a bleb revisions? In one study, it has been found the cumulative probability of total success was 100% in the day 1, 93.1% in the first month, 89.7% in the 6 month, 3 months, 72.4% in the 6 month, and 65.5% in the 1 year. Another study shows in a long-term result, it has been seen that 1 year survival rate was 51%, second year survival was 41%, and 5 year survival was 26%. So it works. So what is the advantage? Advantage, it's as you can see, it's a simpler procedure, less time consuming, it's less invasive, and of course it's economical because I don't have to put a second GDD, and which is important for a country like ours. And of course, lastly, if the revision fails, we have an option for always option for a second GDD. Just think of a situation when second GDD fails, what we'll do. Thank you.
Thank you, Somendra. So over to you, Dr. Prasanna. Can we have the slides of the other podium?
Good morning, everyone. Thank you, Scientific Committee, for the opportunity. So we all know why a GDD fails in the long run. It's mainly because of the encapsulation of the fibrous capsule surrounding the plate. We have already seen the options: diode, another tube, or we can just revive the first tube by needling or MMC injection, or as demonstrated, bleb wall excision. Now we have the option of GAT also. If you have a spare conjunctiva, you can also try trap, or you can just refer to someone else. Since we have different options, it is so clear that there is no clear consensus on the management after a failed GDD. So before going to the second tube, this decision depends on the other eye status, the patient's understanding of the disease, the location of the first implant. So if you have a supratemporal one, you can also try an infranasal implant later, and also the prior surgeries the patient had. Of course, the status of the sclera. So this is one patient who had extensive scleritis, so we cannot plan tube in this quadrant if you're planning the second one. It also depends on the status of the cornea, the anterior chamber depth, and the prior implant complications, whether the patient had any plate exposure or tube exposure. Above all, the potential for vision. So when you're planning the second tube, it's important not only to look at these spaces, but also look at the elephant in the room, that is the tube in the anterior chamber. If you already have a tube in the anterior chamber, the second tube, if you're making the decision, you should be careful. You don't want to compromise the cornea. So again, this second tube decision is dependent on all the prior complications that you have had in that eye. So capsule excision, this is one study which is really old. It was found to be effective in about 75% of the cases, but it is difficult. We know that it's bleeding is an important issue, and of course the bleb wall comes again. So what about shunt revision versus additional tube implantation? So this was a retrospective study. They had good results at 2 years. The main complication, as expected, the second tube was corneal edema. But the one problem with this study is, so there were no standardization for the second implant. If you had used Barwell, the second implant can be AGV or Barwell. So that was not standardized in this one. So if you're planning a second tube, what tube to use is not, we don't have a clear idea as to what has to be used. So what about children? So if we are mainly worried about children because they are the ones who have a long life, and they are the ones on whom the tubes will fail. So this also found reasonable success with the second GDD, where in most of the cases, the first GDD was an Ahmad implant. But the catch here is most of the eyes will need a third intervention. So it is not like everything will get over with the second tube. So coming to diode, so diode is a good option, but this debate is only about excision and tube, but I'll just cover about diode also. So failed GDD, you can try diode also. This study is interesting because the second tube had good initial success, but the CPC had late failures, relatively low late failures. So this is one RCT which compared second tube versus diode. So relatively both were okay. As expected, GDD had more clinic visits and risk of additional glaucoma surgery. So after failed options, after a failed GDD, both were reasonable options. So you should know when to stop. So though I'm talking in favor of second tube, but if you have a bad cornea and a bad conjunctiva, don't just go for second tube. It is better to stop with diode. So too many tubes are not good for the cornea. If at all you're planning a second tube in an eye, if it's a pseudophakic eye, always put the tube in the sulcus. Do not put the second tube in the anterior chamber. So we have to remember all glaucoma surgeries fail, of course, with time. So above the glaucoma progression and IOP, consider the patient's quality of life before advising any surgical intervention. Thank you.
Thank you, Dr. Prasanna. So I would invite Dr. Alokesh to summarize and give his view of what he has to say about these two topics. And can I have the timer for 2 minutes?
Very, very well presented by both Dr. Shomendra and Dr. Prasanna, because this is a question which has got multiple dimensions, as both of them have actually clarified that there are varying situations in different patients, and not one size fits all. But specifically, I would also say that there are, like Dr. Prasanna has mentioned, certain eyes in which even thinking or planning for a second tube surgery is difficult on the clinical appearances of the eye. And secondly, we have mostly seen literature or videos, surgical videos about excision of the fibrous plate over the AGV valves, but for the Barwell implants, it might not be that easier to do the excisions. But one option might be to explain to the patient, and depending on the circumstances on the table, plan for a second tube which is kept in hand, a second AGV implant. That might be a way out. But I would like to take the opinion of Dr. Barton and our international faculties on whether they would explore, and if they cannot, if they do not feel comfortable, that the excision would serve the purpose, then implant a second valve. And in that case, if removal of the primary implant helps in a better clinical outcome for the second valve implant at the same sitting.
Thank you, Alokesh. So now I invite Dr. Keith Barton. We all know Dr. Keith is a master of complicated glaucoma surgeries and especially the tube surgeries. So Dr. Keith, your insights on this.
Thanks. The tubes, you know, it's slightly different from trabeculectomy in that if you're adding a second tube, it can be remote from the first, and there is a certain logic to the idea that, you know, two works better than one. And often when a tube fails, or it's you know, they're starting with a pressure 40 and the pressures end up being 25, which isn't exactly a failure. And in that situation, there's a logic for adding a second one, because you're probably going to get the same benefit again. And that's very much what we tend to do in practice. I have done capsulectomies and things in the past, but they're never quite satisfactory. They tend to scar up again. We tend to, you know, I've noticed nobody's mentioned anti-scarring drugs, and we tend to use mitomycin in pretty high doses. So the encapsulation rate is lower, and I don't tend to use amide valves because they do encapsulate a lot. So we've traditionally used the bar valve for the last 25 years, and more recently the pole. But so I don't particularly like excising capsules. I don't like the idea of buying time, because you don't buy time. You never buy time. Buying time's a euphemism for kicking the can down the road. It's for pushing it down. The patient's always worse. So you haven't bought time. You've let the patient get worse. And I hear this over and over again at meetings about buying time. You've got to be very careful, because it's not that the field's stable. They're going downhill. So by the time you do something else, the patient's worse. You haven't really bought time. So the problem is, if you've got a tube that's done nothing, then what do you do? And I think then you've got to probably look at diode, because if you have a tube that's done nothing and you add another tube, is that going to do nothing as well? What's the point? So that's the more difficult one. But we do tend to use heavy doses of mitomycin with tube implants, and that it's debatable whether that gives any long-term benefit, but it certainly obliterates hypertensive phases, and you pretty much never get encapsulated type blebs.
Dr. Keith, what would be your dose of mitomycin for a repeat tube or a
We typically
capsule
use
excision?
0.5 milligrams per mil on 2 big sponges for 5 minutes. I mean, you've got to whack it. You know.
5 minutes.
And I mean, there's plenty of evidence out there that mito does nothing. So either it does nothing, or you're not using enough of it. And logically, we're probably not using enough of it. And I do have colleagues who, you know, kind of put it on like holy water, and then say, well, it doesn't do anything. So the counter argument to that has been, oh well, you know, you're going to get leaking blebs and avascularity. The interesting thing is, when you put mito back at the equator, you see virtually nothing afterwards. You see no avascularity. You don't get leaks, and you don't get any more erosions. But you certainly do obliterate the hypertensive phase, although we've never ligated the bar valves in the US fashion. We always ripcorded them. So there's always some early flow. So it was never
Hypertensive phase.
But that's a pretty much standard procedure is a second tube, unless the first one's done nothing, in which case you got to go.
Thank you.
Much more. That's the difficult one.
Yeah. Thank you, Dr. Keith. So we'll have our next talk now, next debate by Dr. Madhvi Pillai and Dr. Faisal. Would request both of you to take the respective podiums. And we'll have Dr. Ganesh Raman summarizing from the Indian perspective. So we'll go ahead with Dr. Madhvi first. Can we have the slides of Dr. Madhvi and 4 minutes timer?
7. Good morning, all. So today I'll be speaking in favor of phaco mix for advanced PACG with cataract. So when compared to phaco trap, which may be an elephant, phaco mix may be just an ant. But mind you, ant is just as powerful as an elephant. Trabeculectomy has been in existence for more than 50 years with countless modification and countless literature. When we say MIGS, most of you are skeptical. Can we even do MIGS in PACG? Why not just go for a trabeculectomy? And if so, which one do I go for? And aren't we pushing the limits a lot with MIGS in advanced PACG? So why not trabeculectomy? Yes, it is still the gold standard in 2025, but the gold standard is not golden so far, with complications up to 40%, failure rate up to 50%, and cataract in 50% at 5 years. And we are still searching for a better procedure. So do all patients fit the bill? Patients with poor conjunctival surface, poor ocular surface, patients with debilitating illness, they are not fit for TRAP, but they do need glaucoma surgery. Post-op, the story again continues with multiple countless post-operative visits, bleb needling, laser suture lysis, etc. Does the story end there? No. The nightmares of TRAP goes on and on with post-op complications happening, which can happen at any point of time after you do a TRAP. So we all harbor the secret fear, the wipeout. Yes, wipeout is rare, but when we see advanced glaucoma with macula split, we all have this inherent fear whether a wipeout will occur after a trabeculectomy. So MIGS has provided us with the luxury of choice, and with this statistic we can see that the MIGS procedures have doubled. So that shows the impact of minimally invasive glaucoma surgery. Let's come to primary angle closure glaucoma. Yes, it can be technically tricky for novice surgeon considering the iridotrabecular contact, the peripheral anterior synechiae, and the narrow working space. But we can access the trabecular meshwork by goniosynechiolisis, or just a plain cataract removal will improve the angle space. The rationale is that the long-standing peripheral anterior synechiae, which damages the trabecular meshwork and the Schlemm's canal. So in PACG also, the literature is slowly and steadily expanding. And you can see this review article which shows the multiple minimally invasive glaucoma surgery procedures. Mind you, this has been all done in primary angle closure glaucoma. So this has shown good efficacy as well as safety in primary angle closure glaucoma. So when it comes to complication, this meta-analysis shows a complication rate of just 16% with good IOP reduction and AGM reduction, and mixed phaco is superior to standalone phaco. So yes, complications are there, but are you more scared of hypema or are you more scared of bleb-related endophthalmitis, bleb leak, etc.? So hypema, which we can easily manage, and it is usually infrequent and mostly transient. So which one do I go for? Tanito microhook trabeculotomy, GAT, KDB goniotomy? Yes, I do have a number of choices as well. So the key is to get a good synechiolisis and identification of the Schlemm's canal. Then the procedure is same as, the GAT procedure is same as the usual GAT which we do in primary open angle glaucoma. So aren't we pushing the limits with MIGS in advanced PACG? The results are already out. So the 1 year results were good, but the 2 year result, this study is none other by Zulang Chang. So the 2 year results is fantastic with an average IOP decline from 33 to 13, AGM decline from 2.4 to 0.4 with hyphema just 7%. And mind you, again, not even one patient developed a severe vision threatening complication, and just one patient required GDD. And the next question we ask is whether PAS impacts the outcomes. So this particular study showed that the outcome was not correlated the preoperative extent of peripheral anterior synechiae. So we are eagerly awaiting this RCT, the phaco trap versus phaco goniotomy in primary angle closure glaucoma, as well as trap versus goniotomy in the TVG study in again in advanced angle closure glaucoma. So in a nutshell, phaco trap in PACG is associated with serious potential complications, while MIGS offers you an easy path with lesser invasive approach, faster recovery, safer profile, and again, last but not the least, one size does not fit all.
We'll go over with Dr. Faisal.
Yeah, my slides, please. Slides, please. Yeah, very good morning, and very good morning, Dr. Abhin Porwal and the entire team, and for giving me an opportunity. I know Dr. Madhav is a very good MIGS surgeon. I had observed many videos of her, but now she is pushing us for MIGS in advanced PACG with cataracts.
So the man who coined the term MIGS also recommended that Dr. Ike recommended this procedure is for mild to moderate cases of glaucoma, and we are still following that. So what are the problem of miss in advanced PSCG? As she already told that there is a shallowing of the SE, which lead to more obscuration of the angle, more peripheral anechia, and the more chance for trauma like phaco KDB or phaco bang, more chance for maybe descemet tear or anterior capsular tear, and most worried about the IOP spike after the post-operatively, and the more synechiae formation due to goniosynochialysis, and insufficient IOP control, of course. So what are she's told one of the RCT. In that RCT also within 1 year they are told more than 30 millimeter of IOP spike. That worry more about me in case of advanced glaucoma. This is much higher significant in phacogoniotomy group as compared to phacotrabeculectomy group. So what are the literature which support? We know we are doing this combined phaco and phacotrab for many years, and the literature also suggests that the one study recently published in 2013-23 JOG, this also found that the combination of trab or phacotrab have good result as more than 40% IOP reduction with significant decrease in the number of anti-glaucoma medication. Another study that by Dr. Madhav itself suggested that the PSCG has good outcome in advanced angle closure glaucoma. So there is another study from the Taiwan also. They found that they did 75 eyes, and they also found that quality success of more than 75% at 2-year follow-up. So that suggests that these studies all suggest that phacotrabeculectomy is good option in advanced PSCG rather than phacogoniotomy. And another study from Indian study also suggests that the good outcome, even 5 years, they have good outcome of good success of more than 80% at 5-year follow-up in PSCG patients. Similarly, another the large study in Asian eyes also just suggests that significant reduction in the number of anti-glaucoma medication. You can see the slide. There is less than one number of medication after combined procedure for long-term follow-up. So she also told about this study. All the complications are almost similar if we compare phacogoniotomy and the phacotrabeculectomy. Of course, phacotrabeculectomy we have a bleb, so that we have to manage the bleb, so that cannot be considered as a complication. If we exclude that complication, the complications are similar in phacogoniotomy and phacotrabeculectomy. So of course, don't trouble the patient, don't push the patient into more trouble. I'll still recommend phaco-trab or sequential trab for the choice of uncontrolled PSCG with cataract.
Thank you, Faisal. I would like now Dr. Ganesh to come and present his views.
Thank you, Dr. Faisal and Dr. Madhavi. It's a nice debate. Both of them presented very well. And what we have to remember is, in this whole debate, one party which is not present is the patient. So we don't have their views, and it's very important that we inform them what is this procedure which you are going to follow. Now, as Dr. Faisal and Dr. Badimon mentioned, you have a bleb on one part, which is you consider as a disadvantage, but the advantage of the bleb is that it can be modifiable. So you have intraocular pressure rise and you can modify the bleb. Whereas if you do a phaco-GAT procedure, phaco-mix, you don't have anything to modify except that you can just pump up the medication, try to reduce the pressure. So in that respect, I think we have to think. And the other aspect of it is technically it's quite tricky for a novice surgeon to do gonioscopy. Even a prominent study has mentioned that 50% of gonioscopies were not done in the study. So gonioscopy is something which you have to practice and do, assessing that in an angle closure is more difficult. So that's, if you have a learning curve, then you should address that. And finally, it's not for advanced glaucoma. You must understand the angle closure disease is asymmetric between the eyes. So you could offer phaco-trab in eye which is advanced, and you could always do a phaco mix in the eye which is less advanced. So in the same patient, you can use both the surgeries, but you can individualize the surgery to the patient so as to make the patient much better and much more happier. Thank you.
Thank you, Ganesh. Dr. Keith, I think we had this talk of mixing angle closure yesterday, so your views on that.
The key word in this debate isn't the PACG, it's the advanced. And Dr. Faisal's already shown eye gamuts come on mild to moderate glaucoma. Patients with advanced glaucoma, you've got one shot to get it right. You know, and people talk about the risk of wipeout and all the rest of it. I've never seen wipeout in the absence of a serious pressure spike after surgery. And people who do phaco with no MIGs, and then, you know, I always say there's two types of doctors, those who don't get pressure spikes after phaco and those who measure the pressure, you know. And I've never seen wipeout without a pressure spike. Obviously, MIGs negates that, so that there is a benefit there. But if you're talking about uncontrolled glaucoma that's advanced, then you're fooling yourself if you think you can get lower enough pressures with MIGs. You can occasionally, but it's hit and miss. You know, so you've got to be, you know, it's all very well being safe, but there's no point being safe if you're not lowering the pressure effectively. And in patients with advanced glaucoma, you have to be aiming at least for high single figures. And what MIGs is going to give you a better than 50% chance of doing that? None, really. And that's the bottom line. You've got to, well, whether TRAB's the best or whatever, you've got to think about what you're trying to achieve. And MIGs is attractive because it's what people know how to do, and they feel comfortable, and it doesn't require much intervention afterwards, and it's low risk. But are you actually helping the patient, or are you just helping yourself?
So, Dr. Keith, actually for advanced glaucoma, when I also did the literature search, we have only 2 studies of 1-year follow-up and 2-year follow-up, and it's a multi-center trial which is already published in JOAG and Asia Pacific Journal also, and as I mentioned, so we need a lot of more publications on advanced glaucoma, and then only we can pass it as a resolution that this is the preferred mode of treatment for advanced glaucoma.
Well, I think it's quite clear. We all know that if you get the pressure, you know, the idea that glaucoma always gets worse and there's nothing much you can do about it is mythology. You know, I inherited a practice from Roger Hitchings when he retired of a lot of people with quite advanced glaucoma who'd had kind of nuclear bomb mitotrabs in the mid-90s, whenever nobody quite knew how to manage the mito. These people had awful blebs, and they didn't all get endophthalmitis, but the point is they had pressures of 7 or 8, and you know, 20 years later, with these, you know, mean deviations of -20, they're not getting worse. They don't get worse if you get the pressure down. And also, not all glaucoma surgery fails. That's not true either. You know, the definite, if you get a tube working well, they keep working.
Thank you, Dr. Keith. So now I invite Dr. Nimrita and Dr. Saiba. So they are going to talk about trabecular bypass. Cutting is better than stenting, and one is going to defend on stenting is better than cutting. And we'll have Dr. Nitin Deshpande from India to give his perspective. And then we have a recording of Dr. Ziulin. She just sent her video recording, so we'll play that about what she has to say. So over to you, Dr. Nimrita.
Yes. Good morning, everyone. My topic for debate is cutting better than stenting. So I will be talking about regarding the cutting procedures of minimally invasive glaucoma surgeries. So minimally invasive glaucoma surgery has shifted the paradigmic shift in the glaucoma surgical management, and it acts as a bridge between medical laser treatment and the future filtering surgeries. So to meet the patient expectations is a quite challenge. The surgery should be cost effective, faster recovery, and with lesser post-operative visits. The various cutting procedures include GAT, KDB, bang, microlot, epsilon, trap 360, and trabectome. Coming to GAT is a procedure in which trabecular meshwork is 360-degree bypass by a fibroline suture. In this paper, we did it showed that the comparison between phaco-GAT and phaco-iStent, phaco-GAT was doing much better with a success of 86.4% at 12 months. Although the complications in the terms of microhyphema was higher in phaco-GAT, but it resolved within 2 weeks. So in favor, the GAT is a most economic mixed procedure, and it has shown long-term 4-year outcomes, and it can be performed in secondary open-angle glaucoma and in patients with prior failed glaucoma surgeries. It has also shown promising outcomes in primary angle closure glaucomas. Coming to next, KDB. In this paper, in this meta-analysis, it showed that phaco-KDB has shown a better success in terms of phaco-iStent at the end of 12 months. Coming to next, Pranav et al. Showed the longest outcomes of KDB, and it showed that there was a significant IOP and AGM reduction at the end of 6 years. In this paper, Serai et al. Showed the outcomes of KDB in angle closure, and there was a significant reduction of IOP and AGM. In this study, it showed that a more phaco KDB showed a better primary outcome than phaco I-stent in terms of IOP, AGM, complication, and success rate. So in favor of KDB can be done in primary angle closure glaucoma also. Coming to next, bang. In this paper, it showed that a 30-degree bang is a safe, effective mixed procedure to achieve the target IOP in moderate to severe primary open angle glaucoma. In this paper, Tanuj et al. Showed that by performing goniotomy in regions of low flow aqueous humor outflow regions provided a greater success rather than performing in a high flow aqueous outflow region. So the bang is a cost effective providing implant free mixed procedure. Coming to next, micro lot. In this paper, with comparison with the micro lot and phaco I-stent, it showed that phaco micro lot was more effective than phaco I-stent. We did a first prospective randomized study and on micro lot, and it showed that the phaco micro lot showed a good outcome in the terms of IOP and AGM. So in favor, micro lot has a shorter learning curve and lesser high femur. Coming to next, absolute goniotomy. In this paper, it showed that a patient after absolute goniotomy showed a reduction of 38% and 31% of IOP. And also we did a comparison between absolute and bang, and it showed that both the groups showed equal IOP control at the end of last follow-up with almost no AGM at the 6-month follow-up. So in absolute, it provides a favorable outcomes with minimal adverse effects. In this case report, it highlights the HPE examination of trabecular meshwork of I-stent implantation. It shows that there is some inflammatory and fibrotic changes over the time which can lead to the stent failure. So the odd points for I-stent, it's high cost. It is done only in mild to moderate glaucoma.
Thank you, Dr. Nimrita. Saiba, over to you.
Thank you. Good morning, everyone. So I will be speaking for the motion that stenting is better than stripping. So just to set the stage, we can argue all day long about which mixed procedure is better for us. But the fact of the matter is that there is no guideline or consensus. And the fact that the glaucoma surgery that you choose, a surgeon chooses, is a very individualized concept. It depends upon the surgeon's comfort, the patient demand, type of practice. But the good news is that glaucoma is so diverse that there is place for all. And so if we understand the scope of each and every procedure, we're going to be able to find the right place for it. Moving forward with this disclosure, I do believe that stenting is a great option when chosen in the right patient though. I primarily recommend it for those patients in which your primary motive is AGM reduction rather than IOP reduction. So let's not say that a procedure doesn't work unless you've known what is the scope of the device, the scope of the procedure that you're doing. The very first I-stent was implanted in 2001, and since then, so it's been the longest standing device in the market and has seen a lot of advancement over time and has still stood the test of times. In 2018, we saw Hydrus implants being introduced. The biggest advantage of the stenting device is the fact that it's minimally invasive in its truest sense. And why this is important is because you ensure rapid recovery, there is least destruction, there is also fewer complications leading to more favorable safety profile. And with the stenting devices, because 98% of your trabecular meshwork is preserved, you can use that trabecular meshwork for future interventions like drug-based implants. You can do a viscocannulostomy, go ahead and do a goniotomy later on in the future. And also stenting procedures have wider applicability, according to me, compared to the stripping procedures. For example, let's take patients who are on anticoagulants. Let's take young patients who you want to preserve the trabecular meshwork for future interventions. Let's even take the examples of combining a stenting procedure with premium IOLs. Now, studies have shown that there is there's a great level of refractive neutrality when using stenting compared to stripping procedures. The reasons being that you may have to deal with inflammation, high femurs, maybe AC wash in the future. You're leaving viscoelastics when you're doing stripping procedures. So all these advantages are there with the stenting procedures. And also the proof of the pudding is in the eating, and I feel iStent has been the most extensively published device in the history of MIGS, with more than 300 publications and follow-up as long as 10 years, showing that 47% patients can be kept with IOP less than 15, 51% are 51% medication reduction, no filtration surgery is required, and even Hydrus has comparable results with suture GAT. But the biggest USP, according to me, is its high safety profile. Time and again, studies have shown that stenting devices have higher safety profile than than stripping devices. And the primary reason that MIGS came into existence was for the purpose of bringing safer glaucoma procedures into our practice so that interventions can be done earlier on in the disease. And that is where the stenting procedures score. And stripping procedures have deaded complications like frightful hyphemas. You can have iododialysis, cyclodialysis, development of peripheral anterior synechiae. And also safer procedures means fewer post-operative visits. Now, cost is a deterrent, but let's also understand patients who are on multiple anti-glaucoma medications are anyway spending 7.7% of their annual family income towards buying AGM. Now, this is a recurring cost for life. Now, this versus a one-time investment into something which also gives you a better quality of life, and insurance cover in the future will make things better. Now, wound healing is also another concern with stripping devices because you know fibrosis is going to set in and...
Saiba, thank you.
Thank you.
Dr. Nitin.
Dr. Saiban and Nimrita have made their point very clear and they have advocated their case very well. One thing we have to understand is that trabecular meshwork is a living structure. It is an active aqueous management system, and it has mechanosensitive. It's mechanosensitive also. So when you are removing a trabecular meshwork, you have to be conscious about these things. Take it either incisional surgery or a stent. The distal collector channels and status of your Schlemm's canal is what is going to decide how is your outcome going to be. And in today's day, we really can't assess how is your Schlemm's canal or how good your collector channels are functioning. Regarding stent, something like iStent or the cost, it's not very cost effective at this point. However, it is really less traumatizing to the trabecular meshwork, and we always have other options open for the future. Regarding cutting technologies, we don't know how much to cut yet. Many studies have shown that even 90 to 120 degrees cut in the trabecular meshwork is enough, and you really don't have to remove 360 degrees. However, jury is still out. Problem with incisional surgeries is more inflammation, incidence of hyphema. So all these things we have to keep in mind when we... And at the same point, something like Bang is really cost effective for the Indian scenario. So I think both these procedures you have to be, you should know what you're comfortable with. You have to select your patients rightly, and the jury is still out that which is the better one. So only the time and the larger randomized controlled trials will answer this in the future.
Thank you, Nitin. Can we have the video of Dr. Zilin Zhang? So she's not here. She couldn't get the visa. She's not able to come, but she sent her Zoom recording. Can we play
Hi, this is Shulan. Thanks all the debaters for sharing their thoughts today. Stenting, such as iStent, the most commonly performed MIGS in the US, is designed to create a permanent opening, bypass the trabecular meshwork, and enhance aqueous outflow. In contrast, cutting, such as a goniotomy GT, allows surgeon to incise or remove diseased trabecular meshwork to provide a large area of access to connector channels. When comparing this approach, it is essential to evaluate their efficacy, safety, technical difficulties, and costs. First, going studies suggest that cutting may provide better IOP reduction than stenting in OAG. Our published research in JOG and AJO demonstrated that 110-degree GT achieved a 30 to 40% reduction in IOP, whereas other studies showed that the iStent typically lowers IOP by only 10 to 20%. This larger effect could be explained by the fact that more connector channels are accessed with GT compared with iStent implantation. Second, both procedures are safe, with the most common complication is high femur. However, this complication is typically limited and clears fairly quickly. Third, standing requires both anatomical familiarity and proper devices positioning within lens canal. If the stand is mixed place or malpositioning, IOP control may be suboptimal. This is a skill that requires specialized training, including a shorter learning curve for surgeons. Fourth, most remain a consideration, particularly against PACG with or without cataract respectively, and could be alternative to phacotrabeculectomy or trabeculectomy, which findings has been recognized and publicly of facing patient with narrow angle cutting stands out as a superior choice. Remember, cutting is not just an option. It's an essential foundation for angle-based surgery. It is the most cost-effective procedure we have so far. Thank you.
So now we have our next debate by Dr. Rashmi Krishnamurthy and Dr. Vijay Kumar, and Dr. Devendra will be summarizing from the Indian perspective. And we'll have Dr. Benjamin summarizing for this debate.
So good morning once again. So I would want to tell that GAT 360 degree is the most effective mix today. With all the discussion of why mix, because of the complications of trap, the problems with implants, we have lot of advantages of mix that has already been discussed. And today I would like to tell the Schlemm's canal opening surgeries like GAT and KDB. Various indications, especially open angle, both primary and secondary, post failed filtration surgeries, and nowadays even in angle closure glaucoma. Main contraindications basically are new vessels, anticoagulants, and bleeding disorders. Others are all relative contraindications. So coming to GAT, it was described by Dr. Grover, minimally invasive 360-degree trabeculotomy, and we can use sutures or illuminated microcatheters, and we've been using the cost-effective umbrella-tipped 50-proline suture, which is very easily made with the help of a heated metal object. So this is a GAT in a patient who has had a failed AGV because of the hypertensive phase. After the cataract surgery, so this is the incision over the Schlemm's canal, and the 50-proline suture with the umbrella tip is passed into the angle, and it is threaded into the Schlemm's canal and gradually progressed. And then at the end of surgery, we see that the other end is visualized, and we pull both the ends, and 360-degree trabeculotomy is completed. The challenges are the bleeding, both intraoperatively as well as postoperatively, and can have false passages in the early career. The routine postoperative follow-up and the care as of cataract surgery, and we can see a trabecular shelf in successful GATs. So this is one of a study which has got good results after failed trap also. Though the complications are there, but they are transient and managed medically, most of them. So KDB, because the doctor will be talking about it, I will not go into the details. So to compare between GAT and KDB, one is the degrees of treatment. I think many of us like elephants here, so we have put the elephant picture. So definitely it has a wider approach, and GAT and KDB has around 90 to 120. Head-on comparative studies have found 3 where GAT is being compared with KDB goniotomy. One is in JOAG. We can see both IOP reduction as well as AGM reduction is better with GAT compared to KDB, and also the success rates. This is another study in uveitic glaucoma. This is the same study where it says that reduction of IOP and the complications are comparable. Another study in steroid-induced and uveitic glaucoma 2-year outcomes. Here also we can see that GAT outcomes with IOP as well as AGM reduction is better, and also the survival rates are better with GAT compared to goniotomy. The next is the cost. Definitely KDB is costlier, which can be afforded by only richer patients, and GAT can be done in all kinds of socioeconomic background. Yes, bang is there, but the outcomes of bang or the surgery is little ragged edges it causes. And the learning curve, if we have good visibility, I feel it's not a rocket science to learn GAT, and we do have a faster learning curve for GAT. So to conclude, I would say that GAT 360 is better in both terms of both IOP control as well as AGM reduction. And now with experience, we know that MIGS is not only for AGM reduction, it does reduce IOP even in preoperative higher IOP patients also. Thank you.
Thank you, Dr. Rashmi. Vijay, over to you.
Yes, sir. So good morning, one and all. I would like to thank Dr. Amit sir for giving me this excellent opportunity. Less is more. Let's see why. The glaucoma being such a progressive disease causing irreversible damage, intervention glaucoma is a way to go. Rather than waiting and watching the retinal ganglion cells die one after the other till it reaches advanced stage and intervene with a 360-degree procedure or a trap. Coming to the limited angle surgeries, that is BANG and KDB. BANG being most cost-effective mix available in the country, which we use 25, 26, 27 gauge needle, which is bent at the tip opposite to the rexis needle. It is a real game changer in the Indian scenario. Curved dual blade, everyone knows the technique and advantages. Comparing with GAT, a procedure which requires steeper learning curve, a longer duration of the procedure, and higher chances of high FEMA and AC wash. A mechanism, while doing a limited angle surgery, the visual quality and outcomes of patients have been showing better scores comparing with GAT. And with the mere notion that more area of involvement gives better IOP control is a myth. It just causes more trauma and inflammation and more often high FEMA. The limited angle surgeries, there is reduced trauma to the Schlems canal and lesser inflammation, and with better targeted approach resulting in better segmental outflow, and it also has an optimized healing response. Again, comparative studies shown that the IOP reduction of limited angle surgeries is comparable with GAT, which is 20 to 30 or up to 40%. But it is easier to learn, it has lesser follow-up and minimal bleeding, and lower incidences of high FEMA post-operatively, with quicker return to daily activities. And talking about GAT, there is comparable IOP reduction with doctor needing proficiency in catheterization, longer duration of surgery, and higher incidence of complications like high FEMA and choroidal effusion. The IOP reduction is definitely comparable with GAT with lesser chances of complications. Complication rates of high FEMA is very less with limited angle surgery compared to GAT, which is up to 40%. The postoperative IOP spike again is lower in limited angle surgery with lesser corneal edema and shorter procedure time. And the learning curve is again easier to moderate, while for GAT it is steep. Medication reduction analysis also shows that GAT shows slightly better medication reduction, still it is not statistically significant in most studies. So to summarize, limited angle surgeries give shorter procedural time, lower risk of high FEMA, faster visual recovery with gentler learning curve and comparable IOP reduction. And in 360-degree surgery, it is potentially higher chances of complication with complete angle treatment. It may benefit in advanced cases, but with higher complication rates and longer procedural time, and definitely a more difficult technique to master. So this is a summary. For mild to moderate cases, limited angle surgery is a way to go. In advanced cases, definitely we can consider GAT for maximal IOP reduction. But in elderly and high-risk patients, again come back to limited angle procedures. In a prior failed trap also, limited angle surgery is definitely the first alternative. So in a patient-centric approach, definitely not one size fits all. KDB and BANG for cost effectiveness and lesser risks. For most of the cases, this is the conclusion that limited angle procedures should be considered first line in mix. Thank you.
Thank you, Vijay. Devendra, you have experiences of performing both limited versus 360-degree. You have published a lot of data on mixed surgery, but
So,
your views on this?
So good morning all. So I'm really in difficult situation because I do a lot of GAT and I do the lot of other segmental surgery also. Though the both of presenter really they presented very well. They make my way very easy. So Vijay put the last slide, the patient-centric approach. I think that's somehow the best approach we should have. Do you have my presentation? So really coming to the GAT or 360 degree. Really, still really we don't know how much angle we are treating, how much autocollector channel we are going to entertain, if we are putting the eye stand or doing the limited goniotomy, even the KDB. So if really we still in the learning phase of how the collector channel, how the veins is going to outflow channel, after doing the limited side, how much outflow is going to, there's no measure till now actually. Probably the OCT angiography is the future that can predict the outcome of the limited goniotomy surgery. So really I am still confused. Should we do the circumferential GAT or do the segmental GAT? So what are the literature they already showed? Really the GAT has a very good outcome in compared to limited goniotomies. Whatever you do, either do Tanito, KDB or other goniotomy, so many lean instrument is there, we do limited goniotomy, absolute goniotomy, whatever you do. But look for the literature. Literature is clearly proven 360 degree dramatically reduce the IOP. But problem is this, so hyphema is the only main concern. So but the hyphema, whatever the literature says, if patient have the hyphema, you can clear it, wash it, and your outcome doesn't affect at all. Looking for the 360 degree, just like anything, comprehensive approach, increase the overall outflow, enhance the outflow, higher success rate, only potential complication for the hyphema and IP spike that have to keep in mind. When we looking for the limited goniotomy, really limited recession trabecular meshwork may reduce complication, but the IP control also limited, that also have to be keep in mind. So last I would like to summarize in way, whatever you do, your decision should be patient-centric, depend upon the severity of glaucoma, how much target IP you want, and what is the patient consent, what's the economics of the patient, and affordability and systemic factor. So conclude, do whatever you want, what works on well and what's good for your patient. When you want low IOP, go for the 360 degree. We want the moderate IOP control, you go for the limited goniotomy. Thank you very much.
Thank you, Devin. So, Dr. Benjamin, your views.
Thank you, the speakers, for presenting both sides of the argument here. So just to give you an American perspective, we have availability of other MIGs in the United States, including something called the Omni, which is a combined canaloplasty and goniotomy. This is capable of doing 360 degrees of goniotomy, but most people in the United States only do 180 degrees. And that's because studies have shown that 180 will provide similar IOP lowering without the higher risk of hyphema. And I'm sure all of you have taken care of patients with hyphema, and yes, most of the time it resolves, but I had to take a patient back just a couple of weeks ago for an AC washout. And fortunately, that patient was very understanding, but not all of our patients are. An important thing to consider, though, is this idea of precision medicine, of knowing who should we do more for. I agree that less is more often is the case, but not always, and there are certain patients who probably would benefit from 360 degree GAT, but we don't know who these patients are. And so part of the challenge here is understanding outflow physiology, right? Where are the collector channels? Should we be targeting areas of high flow or low flow and recruiting areas that may not be functioning as well? I will say that studies demonstrate that about half of the angle can be occluded without the pressure going up. And so that suggests perhaps you only need about 180% of your distal aqueous outflow pathway to be exposed, and that perhaps this is why 180 degrees is sufficient. So I will say this is important to consider with your patients, but when we have compelling evidence that less goniotomy can provide similar IOP lowering effect, I think we have to take that into account.
So Benjamin, actually, when I looked at the literature also, only Dylan and the team have done this comparative study, but there's no enough literature available that how many degree goniotomy is the best. So we have a study which is recently published by Tanuj, and he has shown 30 degree goniotomy is giving effective result. So we still don't know how many degrees of goniotomy is going to work best. So whatever patient-centric approach both of you have mentioned, I think we should go ahead with that.
Yep.
Yeah, thank you, Dr. Benjamin. So our last debate is by Dr. Riddhi and Dr. Neha. And we have Dr. Shibal over here. So this is a very interesting topic, not only for glaucoma specialists, but more for the cataract surgeon. And let's see what these two have to argue about and what Dr. Benjamin and Dr. Keith are going to talk about it. Over to you, Riddhi.
Good morning, everyone. I'm going to be talking for the use of advanced monofocal lenses to be routinely used in glaucoma patients. I have no financial disclosures or any conflict of interest. Over the past few decades, our needs and specifications from the ideal intraocular lens has really changed, with patients demanding highest quality of vision across different ranges without any unwanted visual disturbances. As glaucoma specialists, we really need to ask, do these lenses cause any reduction in contrast sensitivity? Do they cause visually disabling photic phenomena? And do they have any deleterious effects on the visual fields? The extended or the enhanced depth of focus lenses extend the patient's range of vision into the intermediate range. They can be diffractive or refractive in nature, or they can even be hybrid, encompassing both the diffractive and refractive components, or they can be based on the pinhole design. On the other hand, the advanced monofocal lenses provide good distance and intermediate vision without compromising on the visual quality. The commonly available lenses in the market use the concept of asphericity or positive and negative spherical aberration to give us this range of vision. What does the evidence say? A recent systematic review and meta-analysis was done to evaluate the efficacy and safety of these EDOF lenses versus trifocals and monofocal lenses. And multiple studies have shown that these EDOF lenses and the advanced monofocal lenses provide good distance and intermediate vision. However, as glaucoma specialists, we are really focused on the contrast sensitivity aspect of these lenses. And it has been shown that these EDOF lenses have better contrast sensitivity, at least as compared to the trifocals lenses or the multifocal lenses. In fact, the refractive EDOF lenses have better contrast sensitivity profile as compared to the diffractive lenses. The advanced monofocal lenses, on the other hand, have a contrast sensitivity profile very similar to that of the conventional monofocal lenses. A comparative study done across 3 commonly available monofocal plus lenses available in the market showed similar contrast sensitivity profile, very similar to that of a conventional monofocal lens. Another study done to evaluate the mini monovision approach with these lenses showed that both lenses provide good uncorrected distance and intermediate visual acuity. However, the advanced monofocal lenses provided good contrast sensitivity as compared to the EDOF lenses, but this difference was not statistically significant. The French Glaucoma Society has come up with rules and some guidelines for the use of these lenses in glaucoma patients. And they found that the monofocal plus lenses are safe to be used across varying grades and severity of glaucoma. The EDOF lens, especially the refractive lenses, are safe to be used in ocular hypertension and in early glaucomas without any signs of progression. In patients with moderate glaucoma, it is important to have an open dialogue with these patients and understand their visual needs and their need for intermediate vision. To conclude, our choice of intraocular lens would really depend on the severity of glaucoma and the visual needs of the patient, and it's important to devise a personalized treatment plan. The refractive EDOF lenses have good contrast sensitivity profile as compared to the diffractive or the multifocal lenses. The monofocal plus lenses give good depth of vision while preserving the contrast sensitivity. Adding minimally invasive glaucoma surgeries has been proven to be refractively neutral and does not affect the vision outcome. So in today's day and age, where most of our life has occurred at 66 centimeters with our life encompassing in our tablets and our gadgets, it would be unfair to not offer our glaucoma patients this intermediate range of vision. Thank you.
Thank you, Riddhi. Over to you, Neha.
Thank you, Dr. Amit, for giving me this opportunity. So today I'm talking against advanced and enhanced monofocal IOL should routinely be used in all glaucoma patients. So I have no financial disclosures. So when I searched upon PubMed finding glaucoma and enhanced monofocal, I could only find 3 results. And if we look at the first study here, it showed very successful outcomes when these enhanced monofocal lenses were used in glaucoma patients. But what was striking here, that contrast sensitivity was not even a part of their primary or their secondary outcomes. Moving on next, this second study, again, they showed very successful outcomes. But if you will look at their stringent inclusion criteria, which had only patients with a very early glaucoma, look at the average mean deviation of only 3.5 decibels. And the stringent inclusion criteria also had that the patient should not have had any change in the glaucoma medications, any change in visual fields or in OCT over the last 1 year. And with this, they concluded that these lenses are very effective in glaucoma patients. So early and only stable glaucoma. Now, looking at the EDOF lenses, again, if you look at the study, they said that the visual outcomes are very good with EDOF lenses, but again, look at the outcomes. The contrast sensitivity has not been analyzed, and look at the average mean deviation in the EDOF group. It's only 1.6 decibel. Are we even calling that glaucoma? And the number of medication was less than 1 in these patients. And not to forget, look at the financial disclosure of the author. Okay, now moving on next. Again, similar, very stable and mild glaucoma and the funding that we can see. So it's very clear that the results here might be biased. Now looking at the EDOF lenses in normal tension glaucoma, it was a small study of only 16 eyes. There was no comparison group. And even in this small group of 16 eyes, they showed that 4 eyes did have contrast sensitivity, which was less than normal. So, and now this systematic review and meta-analysis, which studied about EDOF IOLs, and there were about 1,336 eyes in this study, and these were not glaucoma patients, but they still concluded that EDOF IOLs resulted in reduced contrast sensitivity and more frequent halos compared to the monofocal IOLs. Here, our comparison is not with trifocals. Our comparison is with monofocals. So the pitfalls here are that glaucoma is a progressive disease, and with deterioration in visual field and contrast sensitivity as the disease progresses, these IOLs can rather impair the outcomes in long run rather than enhancing them. These patients are already on a lot of anti-glaucoma medications which cause them an ocular surface disease, which additionally hinders the contrast sensitivity. Third, the need for there's always a need for trabeculectomy in these patients, or these patients might be planned for phacotrab, so there will be an additionally induced astigmatism. So our purpose of making our patients spectacle independent by using these lenses actually goes useless. Also, many of these lenses are pupil dependent, and we know our glaucoma patients have very rigid and small pupil, and some of these patients might not be suitable for these premium IOLs. Also, these enhanced and premium IOLs come at a cost. We need to understand that our patients are already bearing an additional cost of anti-glaucoma medications and the need for future surgeries. So to conclude, there is a sparsity of non-biased and long-term studies evaluating these lenses in glaucoma patients. These IOLs can actually impair the visual quality in glaucoma patients in long run. They might be suitable only for glaucoma suspects, ocular hypertensives, and early glaucoma with no signs of progression. So coming back to my first slide, I am for advanced enhanced monofocal IOL should selectively be used in only early glaucoma patients. Thank you.
Thank you, Neha. So now we have Dr. Shibal, who's going to give our perspective what we follow in India.
Good morning, and congratulations to both Riddhi and Neha for very compelling, very, very articulate arguments, both for and against the motion. As is true for almost everything else in glaucoma, it has to be personalized to the needs of the patient and what the patient is and where the patient is. And as we step away from the evidence-based medicine to precision medicine, I guess this is a case in point. There is no right answer for this. And for your particular patient, a conversation is what will determine what happens next. Of course, if it's an advanced glaucoma, you have to be very, very clear in where you are headed. But for early and moderate glaucomas, the jury is out there. And it is for you to talk to your patient and come to the best conclusion possible. Refractory monofocal IOLs and monofocal plus IOLs are better ways to go. But I have really nothing to add to what the gracious ladies have been saying. Well done.
Thank you, Shibal. Dr. Benjamin?
Sure. So just to focus on the title of this, it was, should these lenses be routinely used in glaucoma patients? And maybe I was asked to speak on this because perhaps the perception of Americans is that we're always trying to sell premium intraocular lenses. But I have to admit, I'm not a very good salesman, and my conversion to premium IOLs is fairly low. But I will say that I think the data is quite compelling here, that there isn't any reason that we shouldn't consider these types of lenses for our patients who are very motivated to have some near vision. But they need to be very realistic here, which is that these EDOF lenses are not as good as trifocal or multifocal type lenses, and so that they need to have reasonable expectations. Certainly in different countries, the cost of these lenses varies. In the United States, it's very expensive. It's $3,000. And so for us to tell patients that they should be receiving these, I think is a disservice. So I agree with what everybody else has said. There are many factors to consider, but we should not be dissuaded just because of fear of loss of contrast sensitivity here.
Thank you, Dr. Benjamin. Dr. Keith?
So this is always an interesting topic. I run an innovation meeting with Dr. Kuldev Singh from Stanford just before ESCRS each year. In 2021, we ran a panel discussion of senior ophthalmologists, senior cataract surgeons, asking them what IOL they would have in their eye. And as far as I know, none of them had glaucoma. It was chaired by David Chang and Arthur Cummings, and the panel were very distinguished. David Spalton, Richard Packard, Sam Mascott, Marie-Jose Tassignon, Doug Cook, and Steve Schallhorn. And interestingly, not one of them said they would have a premium IOL. But worse than that, they would put them in their wives and their girlfriends, but not have them themselves. And as far as I know, they don't have glaucoma. So cataract's very common. And once we've got a survey, a patient-reported outcome from ophthalmologists who've had premium IOLs, then we'll never really know the correct answer. I do EDOFs in glaucoma patients. Not very many. I've even done one in one of our fellows. He actually, this poor guy had his eye pressure checked on a trade stand at the Royal College meeting in London, just routinely, and found it was 35 and he had a field defect. So he ended up with a trab. This is a glaucoma fellow. And he wanted a multifocal, and I said, you're crazy. So we compromised, and I put an EDOF in, and he's very happy with it. Was a Vivity. But I don't do many, but I was very interested in what the senior cataract surgeons would have themselves.
You said it out.
That's the key.
Yeah.
But the wives and girlfriends, I thought that was even more interesting.
So thank you, Keith. I would request Dr. Keith to present this moment to Dr. Riddhi, and Dr. Benjamin, I request you to present this moment to Dr. Sonika. And I would also request all our presenters to please line up in front and speak the Indian prospective chairpersons and ourselves to be in front for a group photo.